Okay, so in this video we're going to be talking about upper extremity nerve injuries. For the nerves that we are going to be talking about, we are going to be talking about the median nerve and the ulnar nerve. Okay, so since we're going to go over two, I'm just going to start with the median nerve. I already have it pulled up. So here you could see the course path that it runs along on the left upper extremity. So the origin for this nerve is lateral and medial cord. The course it runs is that, as you can see, it runs down the arm and the cubital fossa, and then it travels next to the brachial artery. You can't see it, but I can show you right here. As you can see, there you go. See how it runs along with it? Go, and then Alright, and then the action for this nerve is that it innervates the forearm flexor muscles, one of them being the pronator teres. The origin for that muscle is the medial supercondylar ridge of the humerus, so that would be down here, and then the medial aspect of the coronary process of the ulna, right there. The insertion for this is the medial 1/3 of the anterior lateral aspect of the radius, and then the action for that muscle is that it pronates the forearm at the radial ulnar joint. So just pronate means arm, palm down. So bringing it palm down. The next muscle is the flexor carpi radialis. The origin for that is the medial epicondyle of the humerus via the common flexor tendon. And then the insertion is a palmar aspect of the second and third bases of the metacarpal bones. So it'd be up there, radius side to the second and third metacarpal bones. The action for that muscle is that it flexes the hand at the wrist joint and then it abducts the hand. The next muscle is going to be the palmaris longus. The origin for this is the medial epicondyle of the humerus. The insertion is the palmar aponeurosis and flexor retiniculum of the hand. And then the action for this is that it flexes the hand at the wrist joint and then it stabilizes the palmar aponeurosis. The last muscle would be the flexor digitorum superficialis. The origin for this is the medial epicondyle of the humerus, and the tubercle of the ulna, and then the proximal anterior border of the radius. The insertion is the palmar aspects of the middle phalanges, the index, middle, ring, and little finger. So we go down here. It'd be right there in the hand. The action for this muscle is that it flexes the index, middle, and ring finger. So just flexing down like that. The median nerve also serves as the superficial cutaneous branch of the median nerve. The ones that we just spoke on, as in the muscles, those are the agonists and the synergistic muscles as they work to complete the action and they work together. This is also including the thenar muscles as the synergist muscles. So the antagonist muscles for this nerve would be the supinators, just because those are controlled by the radial nerves, and then the median nerves focus on pronation. The biceps brachii, just because the biceps flexes the elbow and assists in supination, and has the same reasoning that the median nerves assist in pronation. Then the wrist extensors, just because the median nerve innervates the wrist flexors, and the same thing goes for the finger extensors, just because the median nerve innervates the finger flexors, and then the thumb extensors and adductors for the same reasoning. Some motor deficits that can be experienced with this nerve is loss of thumb opposition. So just like when you're able to bring your thumb like that, you won't be able to do that as much, or just flex your thumb. Weakness in pronation, so weakness in putting your palm downwards. Reduced grip and pinch strength. Reduced flexion in some of your fingers, so it's gonna lead to only your pinky and your ring finger going down, so it's gonna look like this, holding up a 3. And then you could also experience some related conditions, just like carpal tunnel syndrome. And then some sensory deficits that will be accompanied with this, like symptoms, would be numbness, tingling, pain in the thumb, index, middle, and then the ring finger. So, how you could treat that with some healing and rehab, that would be treating the underlying symptoms through rest, medication like anti-inflammatories, rehab exercises. You could do nerve glides, median nerve glides, where you're like right here, and up, bent, out, flat, fist. You could do that to help alleviate symptoms, and then you could also do some ergonomic changes to the occupations that you're participating in. So if you're typing, you can have your wrist more at a straight position instead of like flexed upwards like that, and that could provide some relief. And then in severe cases, they may resort to surgery just to release compression of the nerve. So now we're going to get into some injuries that can be experienced with the median nerve. The first one is going to be a supracondylar humerus fracture. So that would be up here. The muscles that would be impacted from this are the flexor pollicis longus, or otherwise known as the FPL, and then the flexor digitorum profundus, FDP. This would result to no wrist abduction, so going outwards with the wrist, and then no forearm pronation, so just like having your arm go down, like palm down. No wrist flexion, so you won't be able to flex your wrist. No thumb flexion, you won't be able to flex your thumb. And then there would be some muscle atrophy in the thenar muscles, and then loss of sensation, so you won't be able to feel as much. Some occupations that may experience this are individuals who are involved with activities that can lead to falls in sports. So if you're in a sport where you could fall onto your elbow or just your arm, that could cause a fracture. Lifting heavy objects, like some type of laborers where they're lifting overhead or putting too much stress on their arms. Repetitive motions, if you're like packing consistently or things like that. Those are just some examples of who can experience this type of injury. Another injury that could take place at this nerve is damage to the wrist, or as we talked about before, a compressed like carpal tunnel, which would be carpal tunnel syndrome. This is one of the most common injuries to do with the nerve and just in your wrist in general. So what is impacted with this is that if there's damage to the wrist, that could be like wrist lacerations, and then like the thenar muscles are paralyzed. If it's carpal tunnel syndrome, there's an increased tissue pressure that could result to like numbness, tingling, and pain. The results for this are loss of thumb abduction, so you won't be able to bring your thumb outwards like that. You may have pain or reduction of it. That could lead to ape hand deformity, so where you're not able to use it as much. And then there's either none or limited flexion to the index and middle fingers, so it'll be like this. It's as if you were only able to use these two fingers, your little finger and then your ring finger. Some occupations that may experience this type of injury could be musicians, where they're constantly using their hands and wrists to play different instruments as they're putting them in different positions. Hairdressers, as they're constantly holding up hair tools and like doing excessive wrist flexion. Even if you're doing your own hair, you don't have to be a hairdresser. If you're cooking consistently, office workers, if they're either typing or writing consistently, you could get it from like gardening, where you're using your wrists excessively, knitting, because it's the same common movements over and over, and then forceful gripping, just because there's a lot of pressure that is being exerted. Okay, so the next thing we're going to be talking about and differentiating from the median nerve is the ulnar nerve. So I have it brought up on Complete Anatomy. You can see right here, it is in the pink. You can see how it differs, and it's kind of similar to as the median nerve. As you can see, it kind of runs the same path. The course of this nerve is that it descends the medial side of the brachial artery, and then it pierces the medial intermuscular septum to enter the posterior arm, which would be the back of the arm, and then the palmar aspect of the hand. So if I were to bring up the brachial artery again, you would be able to see how it runs medially of it, and then you can see how the median nerve goes that way. So the ulnar nerve runs medially, the ulnar nerve runs medially, and then the median nerve runs posterior to it. So the action for this nerve is that it innervates some of the flexor muscles. The first one being the flexor carpi ulnaris. This muscle has the origin of the medial epicondyle of the humerus, and then the proximal ulnar body, and the olecranon of the ulna. The origin for this, the insertion for this is the pisiform, or the hook of the hamate, which are some of the little bones in the hand, and then the palmar aspect of the base of the fifth metacarpal bone. The action for this muscle is that it flexes and adducts the hand at the radiocarpal joint or at the wrist joint. The next one would be the flexor digitorum profundus. The origin for this muscle is the medial aspect of the coronoid process of the ulna, and then the superior anterior medial surfaces of the ulnar body. The insertion is the palmar aspect of bases of the distal phalanges for the index, middle ring, and little finger. The action for this is that it flexes the index, middle finger, and the little finger. Yep. And then last muscle that I would innervate would be the one of the intrinsic hand muscles, which would be the palmaris brevis. The origin for this one is the palmar aponeurosis in the flexor reticulum of the hand. The insertion would be the skin along the medial part of the hand, and then the action would be the wrinkling of the skin from the hypothermic immersion, just when it's in water, so the wrinkling of the skin, and then it would assist in gripping. And then the the ulnar nerve is also contributing to the superficial cutaneous branch of the ulnar nerve. So the muscles that were just talked about and listed are some of the agonist and the synergist muscles as they work to complete actions, and they work together. This also includes the hypothenar muscles, the interosseous muscles, and the lumbricals, as they are the synergist muscles to help assist with certain actions. The antagonist muscles for this nerve are the extensor muscles of the wrist, so that those are innervated by the radial nerve, and then the adductor pollicis longus and brevis. Some motor deficits that can be experienced with this nerve, if it would be due to injury or overuse, would be reduced grip and pinch strength. There would be a deformity in the ring and pinky finger, so unlike the median nerve, which experiences a deformity in the second and third finger, this deformity would be a flexion deformity, so it would be like a claw hand, and so it would kind of look like this, claw-like aspect, and then there would be inability to cross or spread the fingers, and then there would be hand weakness present. Some sensory deficits that would be present would be numbness, tingling, a decreased sensation in the little finger, and then the inner half of the ring finger, just because, as stated previously, that those are the two phalanges that are being impacted. And then there would also be a loss of sensation in the middle part of the hand, and this is also known as paresthesia. And yes, this could also be accompanied with shooting pain down the arm and have some sensitivity to cold. So the healing and rehab for any deficits that are experienced in this nerve would consist of reducing pressure, managing inflammation, trying to restore function, and that could be through bracing, medication, therapies such as PT or occupational therapy, and then ergonomic modifications to daily activities that people participate in, and that could be like reducing pressure from prolonged elbow flexion. So if your elbow is flexed for too long, that could cause pressure in the ulnar nerve. So to fix that, you would just like not have your elbow flex too much. You could take breaks to allow it to go into extension, or just not to have direct pressure into that. Or you could do ulnar nerve glide, and that consists of, there's one way that I know, it's just like you're flicking, so you have your hand like this in a 3, and you go back like that as if you're trying to like put it against your finger, or if you're like throwing like tea back, and you'll feel it right there. Okay, so now we're going to be talking about some injuries that can be experienced with this nerve. So the first injury would be there could be a fracture to the medial epicondyle. This would impact or cause damage to all the muscles that the ulnar nerve innervates. So the flexor capreolnaris, the flexor digitorum profundus, and then the intrinsic hand muscles. This would result to inability for wrist abduction, so away, and then no finger abduction, and then no finger adduction, and then loss of the metacarpal joint functions, and then atrophy to the hypothenar muscles, and then there would be limited thumb adduction, so they wouldn't be able to bring your thumb inwards like that. Some occupations that may experience this type of injury, or different examples would be, another one would be individuals who engage in sports, such as ones that have a lot of throwing or contact falling, which could lead to the fracture. And then again, heavy laborers, construction workers, activities that require forceful and overhead lifting. So that could be like weightlifting or stacking boxes, things like that. And then another example would be like repetitive forceful movements, like if you're using tools often and you're like building, or if you're a carpenter and things like that. The next one, or the next injury type that could take place, would be an injury at the wrist, like for example lacerations at the wrist, just like how we mentioned for the median nerve. But this time the only muscles that would be impacted would be only the intrinsic muscles. This would lead to no wrist abduction, no finger abduction, no finger adduction, and then loss of the metacarpal joint functions, especially for the 4th and 5th, and then atrophy to the hypothenar muscles, and then limited thumb adduction. So just like if there was a fracture at the medial epicondyle, they have a similar results. Some occupations that may experience injuries to the wrist would be individuals who cook, activities that require like repetitive hand motions, like packing, chefs, butchers, bakers, and like office workers where they're typing, and then prolonged pressure. So if you're like an athlete and you're gripping it a lot, or if you're putting pressure in a certain position on your hands, or if you're like riding a bike and you're squeezing too hard onto the handlebars. And then another one would be like holding objects for too long. So you can see this like in hairdressers when they're holding their tools for a long amount of time. So that is today's video on the differentiating of the median and ulnar nerve, and then different injuries that can be accompanied with both, and then the results of those injuries, and some examples of occupations that may experience those injuries.